Okay, and paralytics. All right, so paralytics, also known as neuromuscular blockade agents, NMBAs, right? So neuromuscular blockade agents are going to block the neuromuscular junction, right? Here's our normal neuromuscular junction. We release little acetylcholine here, binds to acetylcholine receptors, and it's going to cause a muscle contraction, right? That acetylcholine is going to create a little action potential. It's going to go down to our DHP receptors, and it's going to cause calcium to be released, and we're going to then contract our muscle, right? So we have two different varieties of NMBAs. We have depolarizing and non-depolarizing. Do they bind to the receptor and activate it, or do they bind to the receptor and just block it, right? So those are our two types. There's only one of the first type, which is our depolarizing one, which is our succinylcholine, right? And succinylcholine kind of sucks a little bit because it's going to cause a widespread depolarization of all our muscles. And not only do you get a activation of this action potential, but you also get potassium. Remember, sodium goes in, potassium comes out. Potassium releases from all cells. So potassium is going to go up by about 0.5 points whenever you give succinylcholine, right? So provider comes in, they say, we want to intubate, we want to give succinylcholine. First thing you should ask, well, the K is 6.2. Do you want it to be 6.7? Right? Because that's exactly what's going to happen. Right? So we got to then say, oh, no. Let's use a non-depolarizing NMBA. And there's only two in the kit, right? There is There is succinylcholine. What's the other one? Rocuronium, right? Rocuronium is great for IV pushes. You don't really see it as a drip, right? But rocuronium is an agent that we give, right? And for paralysis for a patient to relax their airway and to help us intubate, right? The key thing with rock, though, is that it lasts about 30 to 45 minutes. So that is a problem if we are having someone paralyzed but no sedation. So we have to give sedation after rocuronium. Or I should say, when you intubate them, you give sedation first, right? Sedation, then paralytics. But after you've given the paralytics, you want to add some sedation to the picture. Otherwise, they'll be paralyzed without sedation. They'll be awake but with a really great blood pressure and a really great heart rate. And the reason why they're like that post intubation is because someone gave rocuronium and we didn't start sedation. Okay, so sedation is always given prior. So we get someone sedation on board, and then we start a paralytic, whether it be IV push or an IV infusion, right? And IV infusion of sedation is not going to be dexmedetomidine. So dexmedetomidine is going to make you awake and alert, right? We don't be awake and alert and paralyzed. It's like, you got this, right? Just 48 more hours. We'll get you through this. That's not something. It's like nod your head if you can't nod your head. Sorry, all right? So that's going to be a problem. So dexmedetomidine is contraindicated with paralysis. All right. What is a great drip? Is cisatracurium or Nimbex, right? It's like the Nimbex 3000 from Harry Potter, but then also the cisatracurium sounds like a spell from Harry Potter as well. It's like, Wingardium cisatracurium, and then it's going to just go ahead and do its thing. It's going to be non-depolarizing, so it's not going to cause that K release like our depolarizing agents do. It just blocks everything shut down just for the moment, for however long it lasts. And cisatracurium lasts, about 30 minutes or so, but it actually just spontaneously dissolves. So it's one of the only agents out there in the universe that you just give it. You can have no kidneys and no liver. It just says, "Yep, I'm done." It just filters out like Back to the Future, right? It's like, I guess I'm done now, and it just filters away, right? So it's literally like magic, all right? Whereas something like vecuronium is another agent you might see be given to patients for paralysis, and that will build up with liver and renal patients, where cisatracurium doesn't, right? It's great until we run out of it. So like in COVID, we had everybody had cisatracurium. We're coasting. And then you could call a pharmacy, hey, we only got like 2 bags left. Can we switch to vecuronium? So those are the two agents we usually give. Okay, there's such thing as atracurium, but we've evolved. We have cisatracurium now. Okay, and then succinylcholine, as we mentioned, if you're giving an IV push, that's going to definitely raise my potassium. If I raise my potassium, do my vessels dilate or constrict? They're going to dilate because you're getting acidotic, right, with hyperkalemia, and you're going to impair the ability of the vessels to contract, right? They can't contract because you're very hyperkalemic. And also you get acidosis, which impairs muscle activity as well. You get vasodilation, so you'll get a little hypotension, but also you get vasodilation in the brain. And if someone has an increased ICP with a bleed, that's not great. That's going to increase their ICP as well. So neuro patients and renal patients, definitely not given succinylcholine. Okay, and it's one of the only drugs that causes malignant hyperthermia. There are inhaled gases in the OR that can cause it, but if you are inbred, you'll have a gene that will then make you a risk for anesthesia complications, which will cause bleeding to hyperthermia. Right? The genes are messed up, so they cause this spontaneous depolarization continuously and cause this overactive effect in the muscles and cause a rise in the BMR and a rise in our temperature. Okay, and then rocuronium IV push. That's usually our go-to agent, right? And that one you're going to start what afterwards? Sedation. All right, so we started paralytics, and then how do you know that they are good to go? How do you know they are still paralyzed? How do you know that they have sedation? Well, that's different. But how do we know they have adequate paralysis? Because we don't overdo it, right? So tachycardia is great, but we don't want to give too much of it, right? Too much of a great thing can always sometimes be a bad thing. So we want to make sure that we are assessing how much blockade is happening, how much neuromuscular blockade agent use is blocking the neuromuscular junction, right? So as we know, acetylcholine gets released from these little nerve fibers right here via our motor nerves, right, from our peripheral nervous system, and they're going to come down and they're going to innervate our muscles, right? And our muscles will contract normally, right? We contract normally. But what if we have medication in the way, right? What if we have medication? Let's do a different color. What if we have medication that's blocking those pathways, right? Like our non-depolarizing agents, they attach those receptors distally and block the acetylcholine, right? So how do we know do we want every single receptor saturated or just a certain percentage, right? And the percentage you want is about 80-90%, right? That is how much blockage of the neuromuscular junction you want. So how do you know that? Yeah, it's 80, 85 maybe. But how do you know that that is blocked, right? So we use what's called a train of 4. A TOF, a train of 4, and it's going to deliver 4 little shocks down onto that muscle wherever you put the shocks, right? How do you know where to put the shocks? Where we have little electrodes, right? So we have electrodes here, we have electrodes right here over the trigeminal or the facial nerve. We have here over the perineal nerve, not the perineum, but the perineal nerve on your inside aspect of your ankle, or we use the ulnar nerve. You'll see a lot of people use the radial nerve over here. Radial nerve is actually, on the thumb side, right? With your thumb, you can make an R, right? Or however that is, right? Well, you can't make an R or with the other fingers, right? So your ulnar nerve is on this, medial aspect of your hand, right? So that's where we put our little leads and we attach our train of 4 to it, and it's going to deliver 4 shocks. Right, so there are 4 shocks, I think it's like 0.4 milliseconds apart or something like that. There's 4 shocks, and you're going to be able to see those shocks going to be able to contract your muscles. Because this impulse, whether it comes from acetylcholine or from an external source, will contract your muscles, right? Not sure if you ever did this experiment in physiology, but that's what you did. You contracted your muscles when you deliver the shocks, right? And at the break, we can grab a train of 4 so you can actually see it happening, right? So that will then cause the muscle contraction. If I have neuromuscular blockade agents in place, it's going to cause less shocks to get through, right? And 80-90% block, then I can get only 1 to 2 twitches through. If I have 0 twitches, right? I did 4 shocks and 0 twitches, that means nothing got through, no impulse that got through to that muscle. That means my neuromuscular junction is saturated. It's 100% saturated with neuromuscular blockade agents or paralytics. Right, so we don't want that to happen. That's going to overdo it. So we only want 1 to 2 twitches. That's going to be ideal. That's going to tell us we have 80-90% of our neuromuscular junctions blocked, right? And if it's blocked there in the radial, it's going to be blocked there in the diaphragm, right? Which is usually why we start paralytics, or like ICP-wise, it can be used to reduce oxygen requirements body-wide. Okay, so that is called train of 4, right? You're looking to see how much percent block is blocked, right? So you're blocking the junctions to begin with the paralytic, and then we don't want everything to be blocked. We don't want 0 twitches to happen after 4 impulses. We want to see 1 to 2 twitches, right? Or 3 to 4, or let's say 2 to 3 to be blocked completely. Okay, so that being said, so this is usually done prior to starting a paralytic. Like if someone's getting like a rocuronium for intubation, you're not going to give you're not going to be doing train of 4s. But if you're going to give a infusion of paralytics, yes, you're going to be doing train of 4s to get what they were at baseline, right? That way if it requires 40 milliamps for a young 5 foot female, or it requires 60 milliamps for a bigger muscular guy, right? So we want to make sure we're not giving 60 milliamps to everybody, because otherwise it can start causing some more discomfort, right? So what is the max you should give, though? Don't really exceed 60. It's like, I don't get anything. We're going to 80. We're going to 120, right? We're going back to the future. No, that's not going to be, that's way too much, right? So we want to make sure that we are, usually stopped at 60. But sometimes it might only require 30 milliamps for an older grandma, right? So we usually get what their baseline is, and we add about 10 to 20 on top of that, right? So we usually go up about 5 milliamps above that, right? And you kind of crank it up just a little bit, you get 4 solid twitches, right? So you can see here you got 4 solid twitches, but you can see they blocked a good percentage of their the impulses, because they are on a paralytic medication. Beforehand, like if we were doing this on a patient that wasn't getting paralytics, it'd be, you see all 4 of those columns all the way at the top, because they got full muscular capability. Okay, what else? So we talked about the sites, right, where we can use it. You want to use these NMT electrodes. If you use the regular electrodes, they don't conduct the electricity as well as a cardiac electrode doesn't conduct electricity as well as a NMT electrode. It's like laced with like silver or something conductive, right, throughout the whole thing. Whereas you look at a cardiac electrode, it's just in the middle has a little nub that's metal, and the rest of it's all plastic and hydrogel, right? So it's not as great as an actual NMT electrode. All right, so factors that affect our ability of our this impulse we get through are also things that would cause us to have a toxicity with our paralytics, and also cause the paralytics to stick around for longer. Or they have a neuropathy to begin with, right? The nerves don't work good because they have diabetes, or they have a obesity, edema, right? That's going to cause, that's going to be also edema of the myelin sheaths and of the nerve fibers. So it's not going to be able to conduct the impulse as well, right? They might require more medication. And steroids, they also are going to impair the ability of our neuromuscular blockade agents. You might require more, or you might have an additive effect where the agent sticks around for longer because you're someone getting steroids. And everyone's usually getting steroids, especially if they have ARDS, they're getting steroids and paralytics. So it's something to be aware of. It worsens patients' mobility recovery when they get steroids and neuromuscular blockade agents, right? And electrolytes like potassium, et cetera. These guys are going to impair our ability to conduct and also require more medication, or it also cause a synergistic or an unsynergistic reaction, which is I should say a non-favorable synergistic reaction. Okay, so you mentioned the goal is about 1 to 2 twitches, right? So that's, I didn't move that at the break. So about 1 to 2 twitches are going to be what are our goal, right? So that means we have 1 twitch out of 4. That means we have 90% blockade, right? I've written over this like 75 times. When you see I get 1 twitch, 1 out of 4, it's about 90% blockade. That means the other 3 twitches were blocked. I used to think it was 25, 50, 75, 100, but no, it doesn't, unfortunately, does not go by that rate. That frequency, right? So we have the manual mode, that's just a train of 4 that we're going to grab, or we have our GE module. You grab a little special module that you plug into the side of the monitor, you plug in your special NMT cable, and you get your special NMT electrodes, and you're going to attach them to the patient, right? And that's going to be able to get a response on the monitor. So there's your GE monitor up top here, right? Otherwise, you're just using your palpation technique, and you're palpating the fingers right here for 4 twitches. If you have 4 twitches, hopefully it's before paralytics, but if you have 4 twitches on paralytics, that means you can go up or down on them. You're going to go up. I heard up and down. We're going to go up on them to provide more neuromuscular blockade until we get how many twitches? What's our goal? 1 to 2 twitches, right? So 1 twitch means I got 90% blockade. 2 twitches means I got 80% blockade, right? And then once we're on paralytics, what about the sedation? It's like, oh, who cares? They were good when I put them under, right? Because we know they can develop tolerance to it, they can develop tachyphylaxis to it. They might not be adequately sedated, right? And you wake them up, it's like, hey, why did you sedate me the whole time, right? So we have this BIS sensor right here. So BIS is BIS sensor. And how you need to do that? You need BIS module, and you need BIS cable, and you need BIS sensor. So you need all these things to get a BIS reading, right? And again, it's an averaged EEG from a scale of 0 to 100%. It tells you how much EEG suppression is there. And your goal is to get about 40 to 60% on your BIS, right? That tells you that they are adequately sedated, right? They're going to be unresponsive to verbal, right? They're going to be a deep hypnotic state. They're going to have an EEG pattern that shows hypnosis, right? Not sleep, but it's going to show an increase in the EEG waves for, unconsciousness, right? So it's a process EEG. Again, you need all these things to get it done. and you change it by every 24 hours. Sometimes you get these people change it every 4 hours. These sensors are about $80 to $100 a piece. So please don't change them every 4 hours, and they run out, and we have to buy one from the company at a cool $4,000. So please don't change them all the time. All right, they just get changed PRN and every 24 hours. Again, the goal is 40 to 60. If you're more than 60, that means you are more awake or less awake. You're less awake. You need more sedation or less sedation? You need more sedation, right? If you're less than 40, that means you need to lighten up on the sedation. You need to back it off because the EEG activity is going down to 0. You've totally obliterated all the neural pathways, right? So we need to lighten up on that to get them back up to 40 to 60. And sometimes you'll see someone, you could throw a BIS sensor on someone that is not on paralytics, and you can see if they have like brain activity in the first place, right? Like a post-arrest patient, they might have like 20, 25 because they have very little activity happening. All right, so sedation summary. So we talked about this kind of similar slide to our choice sedation in pulmonary. Same thing. So we're going to titrate to 0, -1. Ideally is no sedation. That's usually our goal, right? If we are 60% or less FiO2, PEEP is 8 or less, you don't really need sedation. We could give other things. We can give antipsychotics, for instance, haloperidol, olanzapine, quetiapine, right, to mitigate the use of IV sedation. This is considered like your PO sedation, right? So we can transition them from IV sedation to PO sedation. You're doing the SAT every shift, that'll get them off sedation, right? If it does not get them off completely, then you're going to start it back at 50% the previous rate, right? And monitor for delirium, because we know that sedation causes delirium directly, right? So sedatives cause delirium, right? Sedatives can cause agitation as well. So we got to get them off sedation, and hopefully you'll mitigate delirium. But if they're on sedation, we got to monitor for delirium. And how do you monitor for delirium? You assess the CAM-ICU. How often do you assess CAM-ICU? It's Q12. So Q12 hours we assess CAM-ICU, Q4 hours we assess RAS and CPOT, right? All right, so look for an underlying cause of the delirium. It might be the sedation itself, right? Always look for the underlying cause of P, A, and D, all right? So of what's causing my pain, what's causing my agitation, what's causing my delirium, right? It could be something as simple as a hearing aid, or something as simple as raising the blinds during the day to get a normal sleep-wake cycle. Okay, and what if sedation is not working? You need more. So we're switching gears, so we're not coming off sedation, we're adding sedation. So you can ask for boluses for pain, right? So they got fentanyl and they got a sedative infusion, you can ask for PRN pain pushes. You can, if they didn't start Tylenol around the clock, you can start Tylenol around the clock to get them off the sedation, right? And then ask for agitation management. So that's our PO sedation, right? So they are on IV sedatives, they're on a propofol infusion, and they're still wild. We can add on quetiapine, as long as they're what's good? The QT is good, right? So QT is good, then quetiapine is good, okay? And then we got benzos, right? Benzos should be the last thing we give. That's something, if we've tried everything else, then we'll consider benzos, right? The other time where benzos might go up on the list is if you are ETH withdrawal or you are having seizures, then yes, let's go. Giving PO antipsychotics does not control seizures, right? And we might have to change our medication, our IV infusion, if it's not controlling seizures as well. Does dexmedetomidine control seizures? No, but our benzos do, and our propofol does. So those are, and which one we choose? We probably choose the propofol, unless they have pancreatitis. Well, shoot, now I got to go to benzos, right? So we have to validate the choice of sedation of this situation. And you might need, if you started all those things, did all the PRN pushes, did all around the clock Tylenol, did PO sedation, then we might need to go to a second IV drip, right? And that's where you're on propofol and Versed, for instance, propofol and midazolam, or you're on propofol and Precedex. That's usually what we'll kind of prefer, right? Or we introduce our friend ketamine to the party, right? But both medications need to have exact parameters on what to do. It should say titrate to RAS of 0, -1. And both of them should say it. One shouldn't say 0, -1. One says -2, -3. How are you doing that, right? And one should say when to start it. Like when propofol reaches 40 mics, start ketamine, right? And when ketamine is down when you titrate ketamine off, resume propofol down to 40 mics. At 40 mics, titrate it off first, right? So ketamine comes off first, and then propofol off last. What's first, what's last? When do you start one, when do you start the other? It needs to be very clear, right? You should just say, oh, that's not working. 30 mics isn't working. Let's start ketamine at this point, or let's start Precedex. So it has to be clear orders. So propofol order and Versed order, these are examples, right? Titrate off last, versus titrate off first, right? And when to do it, right? When do I start the Versed? When do I, add the Versed in place? Okay, should you have a little bit of this, a little bit of that, that's a no, right? Sometimes we'll find a patient on Precedex, propofol, and Versed. And Versed, I got 0.12, propofol is at 25, and Precedex is at 0.6. It's like, what are we doing here? It's like we're walking to like a kitchen that's dirty, right? So you get all these things are going and operating. There's like stoves burning over here, and there's a pot boiling over there. So what are we gonna do to get this patient's sedation under control, right? And they may have had good reasons, like, oh, they're super tachycardic. Let's start Precedex. That will help with the heart rate, right? Oh, they got seizure activity. Let's start some Versed. But then so it's like, oh, let's start propofol the next day. So we need to have a clear plan on our sedation, because we know if we have all the sedation on board, that's going to worsen their outcomes. Okay. If they're unable to oxygenate, you're on 2 sedatives, 3 sedatives even. That's where we're going to start bringing in the big boys, otherwise known as paralytics. We're going to hit the off switch, and we're going to reduce oxygen demand, and we're going to then hopefully oxygenate better, right? Or increase ICPs as well, right? And you never give paralytics for agitation. Sometimes we'll see that. It's like, oh, just give a paralytic so you can go to CT scan. So we get the CT scan done. Like that's not okay, right? You're going to be on some FBI wanted lists at that point.